اوكي اذا هلا راح نحكي عن اليورين تراكت انفكشنز. واضحه عندكم الشاشه؟ واصل البث؟
واضح
دكتور واضح.
Okay. So to start with, urinary tract infections is a term that is applied to a variety of clinical conditions ranging from localized infection of the bladder with lower urinary tract symptoms to symptoms of pyelonephritis with severe infection of the kidney and potential risk of urosepsis. طبعا أهمية إحنا نعرف هذا التوبيك we have to study it very well to reach an accurate diagnosis and accurate treatment. ليش؟ لأنه it is essential for us to limit the morbidity ومortality الناتجة عن ال UTIs. ليش؟ لأنه كمان عندنا ال unnecessary use و prolonged use of antibiotics. زي ما بتشوفوا حتى راح تشوفوا كمان بالكلينيكال براكتس انه نتيجه المس يوز اوف oral antibiotics there is يعني صار عندنا increased rate of bacterial resistant وبالتالي الميديكال therapies are not effective anymore. نيجي نحكي from epidemiological point of view. طبعا الانسيدنس of UTI varies according to the age and to the gender. Prenatal period the incidence is higher in males. طبعا this is most of the time explained by the circumcision status of the child or of the boy. احنا بنشوف الانسيدنس is higher in around 85% with uncircumcised males or boys more than the circumcised one. Later on in life الage group من التشايلد ايج جروب حتى الالدرلي 1 الفيميل بيكونوا هاير انسيدنس. طبعا لها اكثر من فاكتور، اكثرها انه الشورت يوريثرا والكونتامينيشن للبرينيوم. لا عشان هيك اوفر اول انسيدنس احنا بنحكي انه اليو تي اي از مور كومون ان فيميلز ذان ان ميلز. هاويفر بالايج جروب نيونيتال الميلز اكثر، وبالالدرلي بصيروا تقريبا ذا سيم انسيدنس. زي ما حكينا الريسك فاكتورز بالبيدياتريك ايج جروب اهم شيء نحكي عن السيركمسيجن ستاتس. كمان في other risk factors like prior history of UTI, sexual activity among older population. In addition كمان risk factor we have to look for anatomical abnormalities like vesico-urethral junction, urethrocoel, uretropelvic junction, posterior urethral valve. functional abnormalities زي حالات النيوروجينيك بلادر والبلادر and bowel dysfunction، هذول بنشوف عندهم الانسيدنس of UTI is higher. اوكي بس دقيقة راح اغير السلايدات، تسمحوا لي دقيقة.
تمام.
سوري سامعيني؟
دكتور
اوكي سوري بس لانه غيرت السلايدات.
تمام.
كان كمان ان الريسك فاكتورز باليو تي اي لازم نطلع اذا في كمان عندنا زي ما حكينا circumcision status in boy, prior UTI, sexual activity, anatomical functional abnormalities، واخر شيء certain medical conditions that carries a higher risk for UTI like diabetes, obesity and sickle cell anemia. طبعا اهم شيء we have to understand the pathogenesis of UTI. To understand the pathogenesis of UTI, we have to know steps or important factors بالpathogenesis, which are the mode of entry of bacteria, the host susceptibility factors, and the bacterial pathognomic factors. So each one of these is essential in tailoring appropriate treatment for a diverse of clinical manifestation. طبعا المود of entry of bacteria, the most common as the ascending route of infection. عادة بيكون في عندي urethral colonization ومigration لهاي الcolonization والbacterial growth into the bladder, which invade the epithelium mediated by the villi. Most commonly, this is the most common mode of entry, and it's most commonly seen in females due to vaginal and perineal contamination. Other mode of entries like hematogenesis spread, which is mainly seen in immunocompromised patients and in neonates. عادة بالهيماتوجينيسيس spread بيكون المايكرو اورجانيزم mainly Staphylococcus aureus او Candida species او mycobacterium، وعادة بيكون في عندنا البكتيريا هاي travel through the bloodstream. Lymphatogenesis spread زي حالات الريكتال colonic periuterine lymphatics have been postulated as a cause of UTI. Either كمان the last one اللي هو direct extension from adjacent structures like an intraperitoneal abscess or vesico-intestinal or vesico-vaginal fistulas. هلا حكينا عن المود اوف انترست الهوست ديفنسز how our body react to the bacterial invasion. The most important والmain والfirst defense mechanism اللي هي voiding. Voiding means you wash out the urine outside the body, so you wash out the ascending bacteria comes into the urinary tract. Other defense mechanism, there are some microorganisms نسميها normal flora موجودة بالnormal vagina والvagina and periurethral flora. These microorganisms or normal flora produce like Hemolactobacillus, which help to prevent uropathogenic colonization. The third defense mechanism اللي هي urine characteristics. زي ما بتعرفوا اليورين osmolarity, اليوريا concentration, organic acid concentration, والpH, the acidity of the urine. These factors inhibit bacterial growth and colonization. Next comes, there are in the urine some certain type of protein called tan-horseful glycoprotein. These proteins are present in the urine and they inhibit bacterial adherence to the epithelium and inhibit invasion. Epithelial lining itself, it works first as a mechanical barrier. Also, it has a capacity to recognize bacteria in order to activate other immune or innate host defenses mechanism. Lastly, the kidneys secrete some certain of antibodies. These antibodies enhance bacterial opsonization and phagocytosis and inhibit bacterial adherence. So these are the factors that how the body defends itself against bacterial invasion. Now, what about the bacteria itself? What are the factors in the bacteria that make it virulent and invasive? First of all, the villi, which are certain ligands located على الperiphery with tips of the bacterial fimbria. These villi are important in the migration of the bacteria, and also it's important for the adhesion of the bacteria with the epithelium. Second, some bacteria like E. coli produce certain enzymes like the hemolysin, which initiate tissue invasion and makes iron available for infecting pathogens. Third, there are certain K antigens present on the bacteria itself. These antigens are important and to protect the bacteria from phagocytosis and neutrophils. Lastly, certain bacteria form like a biofilm formation or a matrix around it, or make an encapsule that hiding the bacteria from the host defense mechanisms اللي حكينا عنها، وبالتالي بتمنع الديفنس ميكانيزم، وبالتالي بتصير البكتيريا more invasive or more pathognomic. نيجي للcausative agents. Generally speaking, the most common microorganism causing UTI is gram-negative bacilli. This is the widely accepted most common cause. Of the gram-negative bacilli, بنحكي 80% of uncomplicated cystitis and pyelonephritis are caused by E. coli. So there are several other uropathogens like Staphylococcus, Saprophyticus, Klebsiella proteus, Enterobacter, and Enterococci. Also, there are certain microorganisms in certain situations, like in hospital-acquired UTIs. The most common we can find Pseudomonas and Staphylococcus species. In children, however, E. coli is still the most predominant causative factor. However, other causes like Enterobacter, Enterococci, and Klebsiella species are present. Lastly, regarding anaerobic bacteria, lactobacilli, Corynebacteria, Streptococci, not including Enterococci, and the Staphylococci epidermis, these are found in the normal flora of the periurethral area. So usually they do not cause UTI. However, they're considered as common urinary contamination. كيف يعني contamination؟ كثير مرات احنا بنبعث culture for urine culture and sensitivity. Ideally انه بيجينا الكلتشر 1 microorganism او 2 microorganism، بس sometimes بيجينا mixed culture، او اذا شفنا فيها staph epidermis. This means that this sample is not a correct sample to do culture, so these are contamination. So we have to be sure انه the culture was taken in a good manner. And as a doctor you have to look for the culture, not taking any result as it is. You have to think about this result. نيجي للdiagnosis. طبعا standard diagnosis two things. Simply you have to do a urine analysis and urine culture. Sometimes we may take the sample by doing a localization study, but the most important thing ناخذ urine sample, either voiding or localized sample زي ما راح نشوف later on, and then we do urine analysis and urine culture. طبعا مهم بالdiagnosis to diagnose is this a simple or uncomplicated UTI or it is a complicated UTI. It is a much big difference بين الاثنين. Uncomplicated UTI consists of an infection in an otherwise healthy patient with normal urinary tract anatomy and function. So if you have a urinary tract infection, anatomically the person is okay, functionally the urinary system is functioning very good, so it is called uncomplicated UTI. On the other hand, if you have any anatomical abnormality or any functional abnormality that is associated with UTI, this means we have a complicated UTI. For example, عندنا female, young female with a normal anatomy, with a normal voiding, and she has got simple UTI. This is uncomplicated UTI. On the other hand, an elderly male, 75 years old male patient with a UTI that is accompanying a prostatic enlargement and high residual urine and the anatomical and the functional abnormality, this is called a complicated UTI. Urine analysis زي ما بتعرفوا it includes looking for acidity, for color, for different factors, but بالدipstick أو بالurine analysis في another two elements we have to look for them اللي هم leukocyte esterase and the urinary nitrite. Leukocyte esterase is a compound or enzyme produced by the breakdown of white blood cells, neutrophils, and it is around 95% sensitive to UTI. On the other hand, urinary nitrate, this is a product by the reduction produced by the reduction of dietary nitrates by gram-negative bacteria. So now leukocyte esterase reflecting the presence of white blood cells. On the other hand, urinary nitrite reflecting the presence of gram-negative bacteria. الجرام-negative bacteria بتحول النيتريت الموجود بالفود waste product لنيترات, which indicate bacterial growth. So these two elements are diagnostic or give a good suggestion for UTI. If we are taking these two together in the dipstick, the sensitivity of our result will be around 80 to 90%, and the specificity around 60 to 98%. It's important with urine analysis to do a microscopic examination. We are looking mainly for white blood cells, while presence of white blood cells in the urine is called pyuria, and the concentration per high power field or the number of cells per high power field is indicative, and we have to take in consideration the urine concentration status. For example, if the urine is diluted, we can consider up to 3 white blood cells per high power field as a diagnostic. However, إذا كان urine concentrated, we can look at a higher number like 5 to 6 white blood cells per high power field. طبعا pyuria is one of the main findings with urine analysis. We have to look for its differential diagnosis, which include bacterial infection, mycotuberculum or TB infection, inflammation without bacterial infection زي حالات interstitial cystitis من inflammatory processes in the bladder, chronic prostatitis, ممكن تكون associated with malignancy, with carcinoma in situ. So when you find white blood cells in the urine, does not mean it is a urinary tract infection directly. You have to look for a wide differential diagnosis, and then you have to correlate the urine analysis with the urine culture. Urine culture still the most and the gold standard diagnostic technique for the diagnosis of urine culture, urinary tract infections. حكينا عن localization studies. Sometimes we have to take urine sample. The more widely accepted sample اللي هي midstream urine sample, which reflect اللي احنا بنسميها هون ال VB2, which reflect the urine that is stored in the bladder. However, sometimes we can take the first part of the voided urine. We call it first voided sample, or called VB1, which mainly reflects sometimes the urethral colonization. Also, we can take a third sample after the midstream, after doing a prostatic massage. We massage the prostate, we express its secretion into the ejaculatory duct, and then we take a third sample which reflect these prostatic secretions. The last localizing the study, sometimes we have to take urine sample directly from one kidney or from one ureter. Simply we do it through cystoscopy. We irrigate the bladder, we clean the bladder completely, then we insert a catheter inside the ureter till it reaches the renal pelvis, and we can drain a direct sample from the renal pelvis. So these are the localization studies that we can use for urine sampling for the diagnosis of UTI. Regarding the antibiotics, antibiotics is the gold standard treatment, and our aim or our goal is to eradicate the infection by selecting an appropriate antibiotics. So when we have to decide which antibiotic we have to choose, we have to take in consideration the infecting pathogen, the type of the bacteria, and the susceptibility of this bacteria to the antibiotics. If the infection caused by single or multiple microorganism, if the infection is pathogen or a normal flora one, or is this a community acquired infection or hospital acquired infection. ليش؟ لأنه كلها these are differ in the type of the bacteria that cause the infection. The second thing we have to consider when we consider antibiotic is the patient himself or herself. We have to look for patient's allergies, because some medication do have allergies. If the patient have an underlying medical disease, certain medication that are contraindication in certain medical conditions or should be given with great awareness regarding certain medical condition like renal failure. If the patient has previous antibiotic therapy and he has previous sensitivity, or the patient is currently taking a medication, ممكن يصير synergia or overlap. Also the clinical status, if the patient is has pregnancy, is she pregnant or not? These are important factors regarding the patient. The last thing, the site of infection. When considering antibiotics, if the infection in an organ like kidney or prostate, pyelonephritis or prostatitis, we need to give an antibiotic with a pharmacokinetics that give us a high tissue level of or concentration of the antibiotic. However, if it is a simple UTI or cystitis, the infection, the colonization just only in the bladder or in the urine itself, then we can look for a type of antibiotic with which is highly excreted in the urine and high concentration in the urine to be effective. So in this regard, we, as we said, to start with, the most common microorganism in gram-negative bacilli. So we have to look between different types of antibiotics into certain types of antibiotics that cover gram-negative bacilli, like trimethoprim, fluoroquinolones, nitrofurantoin, aminoglycosides, and cephalosporin. Mainly لما نحكي cephalosporin, we are talking about second, third, and fourth generations of cephalosporin, because the first generation is mainly covering gram-positive cocci. Also, we have to look for this table here on the right side. I think you have it in your printout or study material. Certain types of infection or diagnosis or site of an infection do need certain antibiotics, and they can differ from the duration of treatment. For example, simple cystitis up to 3 days. On the other hand, if you look for prostatitis, we can give it up to 6 weeks. So it is important to know the duration of the treatment. Also, print out will study material. Each one of these antibiotics has its pharmacokinetic characteristics, mechanism of action, side effects. It is important for you as a doctor to be familiar with all of these. ليش؟ إنه وبالذات السايد effects. It is important إلك تعرف إنه إذا مريض عنده G6PD ما لازم تعطيه ترايميثوبرين. او اذا عنده سلفا الرجي ما لازم تعطيه ترايميثوبرين او بلكترين. اذا المريض اذا young, for example children below 16 years of old عندهم الكارتريج still growing, we cannot give them fluoroquinolones. ليش؟ لأن الفلوروكوينولونز بتعمل suppression للكارتريج جروث، وبالتالي حرام نعطي طفل فلوروكوينولونز زي سيبروفلوكساسين، ليفوفلوكساسين، حرام نعطيهم. ليش؟ لأنه بيأثر على الجروث اوف الكارتريج والاند جروث بليتس، فبالتالي ممكن يطلعوا شورت. Nitrofurantoin, for example, it is completely excreted in the urine. If you have a tissue infection, prostatitis, pyelonephritis, it is not advisable to give nitrofurantoin. Also, nitrofurantoin has some peripheral neuropathy side effects. Aminoglycosides حكينا انه انها بتعمل nephrotoxicity و autotoxicity. So when you give aminoglycoside, you have to have an underlying idea about the renal status, because if you have a renal impairment, you cannot give aminoglycoside. And if you want to give it for a long time, you have to follow his hearing function وتعمل audiometry مشان وبالذات بالصغار مشان ما يصير عندهم hearing loss. cephalosporin حكينا الجنريشن، مش كل الجنريشن sensitive لليو تي اي او يوز اليو تي اي، وكمان تعرفوا السيفالوسبورين عندهم بتكون cross allergic reactions مع penicillins. So when you take allergy history, you have to look for بنسلين allergies وما لازم نعطيهم سيفالوسبورين. هذا الحكي كلياته موجود عندكم. الاوت برنت راح يكون في ديتيلز اكثر و you can read it from there. راح نبلش ب specific infections. أول شيء pyelonephritis, which is an inflammation of the kidney and the renal pelvis, and it is diagnosed clinically. Patient usually present with chills, fevers, and costovertebral angle tenderness, and sometimes associated or accompanying lower urinary tract symptoms such as dysuria, frequency, and urgency. Sepsis is one of the main complications of acute pyelonephritis, and it has been found that 20% to 30% of all systemic sepsis are resulting from urine infection. So pyelonephritis is one of the most important kind of infections because it carries a high risk for septicemia and septic shock. When we take a urine analysis, we look to the urine analysis, it commonly demonstrate the presence of white blood cells and RBCs. If you do blood tests, then we can find a leukocytosis, increase in the white blood cells, increase in the ESR, erythrocyte sedimentation, elevated CR protein, and these are commonly present when we do a blood test. Also, we have to do bacterial culture, urine culture, and as we said, the most common microorganism in the whole E. coli. Regarding the management, to start with the management of acute pyelonephritis, we have to decide if I'm treating a patient as an outpatient department, as an home treatment, or I do need to admit the patient, because if I have a high risk patient that need hospitalization, then I have to admit the patient. For example, إذا المريض عنده let us say pregnant lady, مريض immunocompromised, مريض عنده borderline kidney function, all of these are important things and you have to admit the patient. However, if I'm planning to احنا راح نخلص خلال 10 minutes. Okay. ان شاء الله بنخلص قبل. If I'm planning to do a home treatment, then I have to start an empirical treatment with aminoglycosides or ampicillin or amoxicillin with clavulanic acid or a third generation cephalosporin, and to start oral with fluoroquinolones or trimethoprim till getting the initial result of the culture. If the culture is sensitive to my antibiotic, I continue. If it is not sensitive, I have to change according to sensitivity. In most of the acute pyelonephritis, the treatment is usually lasts from 7 to 10 days. However, if the patient is not responding or not tolerating oral treatment, I can give it up to 10 to 14 days. Again, certain cases like pregnancy, I have to admit the patient and initiate a parenteral treatment. The second category of pyelonephritis اللي هو emphysematous pyelonephritis اللي هو عبارة عن necrotizing infection characterized by the presence of gas within the renal parenchyma and perinephric tissue. In about 95% of patients, the emphysematous pyelonephritis seen in diabetic patients. Women has a higher risk, 6 times more risk than men. Other factors that contribute to emphysematous pyelonephritis are renal failure, immunosuppression, obstructed upper tract, and polycystic kidneys. These patients usually present with fever, flank pain, vomiting that fails initial management with parenteral antibiotics. Pneumaturia is one of the diagnostic findings of emphysematous pyelonephritis. As we said, the most common microorganism is E. coli, found in 66%. However, Klebsiella is found in 26%. Proteus, Pseudomonas, and Streptococcus are also considered a causative bacteria. The diagnosis mainly is diagnosed on radiographical evaluation. المريض عادة بعطيك نفس البيكتشر تبعت البايلونفرايتس, but when you do like an X-ray KUB, we can see a gas overlying the affected kidney. On the other hand, or also on CT, which is more sensitive in detecting the presence of the gas, we can see the gas على CT. Regarding the management, we have to first of all control blood sugar, relieve any obstruction, and additional to fluid resuscitation and parenteral antibiotics. Now we'll move to renal abscesses. We have different types of renal abscesses. To start with, any severe infection that lead to liquefaction of the tissue and subsequently sequestration and forming an abscess within the renal calyces بنسميه pyonephrosis. If this abscess ruptured into the perinephric space, we can call it perinephric abscess. If it is extended beyond the gyrotous fascia, we call it paranephric abscess. Abscess is most commonly seen with hematogenous spread. However, severe infection, not treated infection, can cause abscesses. Usually, patients present with fever, flank abdominal pain, chills, dysuria, and these symptoms may last for 2 weeks, even with the treatment without being relieved by antibiotic. Al ultrasound, we can find an echoic mass within or displacing the kidney, posterior acoustic enhancement, or lack of vascularity at Doppler imaging. On CT, the CT scan can demonstrate an enlarged kidney with focal areas of hypoattenuation early in the infection. So if the patient with pyelonephritis and you have started treatment for 24 hours, if fever does not subside, we have to look for abscess. If we found an abscess, we have to drain it. Sometimes we can give antibiotic for 48 hours. If it is not relieved, then we have to drain it either percutaneously through a CT guided or an ultrasound guided drainage. Xanthogrammaticus pyelonephritis is another category of pyelonephritis. هذا الكاتيجوري عبارة عن chronic inflammation or infection, usually unilaterally, and this is affected an hydronephrotic or obstructed kidney. طبعا هذا characteristically هذا الكايند of infection بيكون فيه foamy lipid laden histocyte بنسميها xanthoma cells. وهي السيلز تعطي presentation are very similar to lipid laden cells that are found in clear renal cell carcinoma. Patient usually present with a flag pain, fever, persistent bacteria, and history of stones is present in 35%. We can find mass, bacteria, and urine analysis can demonstrate leukocytes, and these patients do have leukocytosis and anemia. E. coli and Proteus are the most common species diagnosed by CT. عادة بنشوف heterogeneous mass. When we give enhancement, this lesion has a prominent blush periphery, while the central area, which are filled with the pus, do not enhance. The treatment عادة هذول misdiagnosed with renal cell. So the treatment comes after doing a surgery for suspected tumor vagina by pathology. However, if you suspect xantho, then you have to consider a nerve kidney sparing surgery. We do partial nephrectomy, لكن إذا كان extended diffuse infection, then we have go for total nephrectomy. Last نحكي الأكيوت cystitis اللي simple UTI عادة هذول زي ما حكينا complicated و uncomplicated. mainly بتكون ascending infection, clinically diagnosed. They present with lower urinary tract symptoms like dysuria, frequency, urgency, sometimes low back pain, suprapubic pain. Urine analysis, the presence of white blood cells is diagnostic, and we have to do culture as well. E. coli the most common. عادة التريتمنت بتكون for short time. Nitromethoprim, trimethoprim, nitrofurantoin, and fluoroquinolones are excellent treatment, and usually the treatment زي ما حكينا short treatment 3 to 7 days. In cases if we have recurrent لازم نميز if two types of recurrent bacteria أو recurrent UTI اللي هي إما bacterial persistent with the same microorganism due to resistant or with another microorganism بنسميه reinfection. Lastly, bacterial prostatitis, inflammation of the prostate. It is uncommon in pre-pubertal boys, more common after the age of 50. They usually present with systemic or constitutional manifestations, fever, chills, rigors, malaise, low back pain. And digital rectal examination reveals a tender, enlarged prostate and irregular surface. Urine analysis, we found white blood cells. Serum, we have leukocytosis, and prostate-specific antigen is high, and this is one of the differential diagnosis of high PSA. Empirical treatment usually start with trimethoprim or fluoroquinolones. Sometimes we initiate a treatment with IV empirically and continue with the trimethoprim, and usually oral treatment 4 to 6 weeks. Patient with sepsis, immunocompromised, acute retention, or have significant medical comorbidities, those need admission and hospitalization. And that's it. I think محمد معي؟
دكتور.
اوكي. اسمع، شو رايك نرتب موعد يوم ثاني نكمل بقية المحاضرات؟
مثل ما بدك دكتور.
اوكي، اليوم الجمعة خلاص بكفي، والله تعبان انا. بنرتب على يوم الأحد مين عندكم؟
الأحد عندنا الدكتور سامر، بس ما بطول يعني نص ساعة موضوعه.
خلص
فيا قبله إشي زي هيك.
ماشي على بركة الله.
الله يعطيك العافية.
في حدا له سؤال؟
تمام دكتور، هسه
ولا اخذ غياب؟
لا، ببعث لك اياه عادي.